recording, just so you guys are aware. And since I'm recording, you guys don't have to put on your videos for this one. But please feel free to chime in and answer any questions along the way. And for the polling questions, if you guys can use the group chat, that would be fantastic. Okay. You guys can see the screen, correct? The PowerPoint screen.
I can see it.
Okay, perfect. I wish that this would not be in the middle of the screen, but okay. So the objectives is that we're going to be discussing common preventive care for female patients and understanding key factors in encouraging adolescents to seek healthcare, verbalize recommended preventive health measures for adolescents, articulate various methods of female and male contraception, assess the best contraception method for a patient, and be able to recognize various STIs and recommend treatments for them. Okay. All right. So if you guys can answer this for me, which of the following is not a preventive service for a 52-year-old female? All right, great. Good deal. Okay. So very good. Pap smear at 52. Yes, she would have lipid screening for sure. Flu vaccine every year. Colonoscopy starting at what age? When do we start doing the colonoscopies? For a normal, not high risk patient.
50 years old.
Very good. Okay. All right, so with cervical cancer screening, this screening has changed very many times over this several years. And I still keep hearing about providers out in the community that are still doing pap smears every year. And it blows my mind. So, and I have clarified, because this is one thing that patients, when you ask them when was your last pap smear, they don't know how to differentiate a pap smear versus a pelvic exam. If the physician uses a speculum, they think that the physician is doing a pap smear. So that's one thing that we all should be better about with educating our patients with, that it's one swab or two swabs out of however many swabs we may be doing during a pelvic exam. Okay. And should we be doing a pap smear every year? No, unless there was a problem with one in the past or like in the last year. But in under 21, we don't screen at all. This used to be very different. We used to screen as soon as people were 18 or as soon as they were sexually active. You know, if they were 14, we would be doing a pap smear. It's now 21 and over. Okay. And then until you're 30, we do the pap smears every 3 years. And if your pap smear has an abnormality, then it will reflex to HPV testing, but we don't automatically order it. For 30 and above, so to 65, we do the pap smears. We do pap smear plus HPV co-testing is a term that you'll hear. And if both of those are negative, then you're good for 5 years, which is, depending on the last time that your patient has seen a doctor, this may be brand new to them. So because like I said, a lot of them are used to getting pap smears every year, or they think every year. And then with a hysterectomy, if they've had a hysterectomy, we don't screen unless they unless the surgeon did not take out their cervix, which again is kind of an odd thing. There was a period of time when surgeons would leave in the cervix. In the past, they were taking out everything, and then they started taking out everything but leaving the cervix. And then we started to again take out everything. And they would leave the cervix because they thought that it was decreasing their sexual pleasure. So they tried leaving that in, but it has caused so much more problem. And I don't know that they've ever verified that leaving the cervix in made a difference. But if there's not a cervix, you don't do a pap smear, unless the hysterectomy was done because of a cervical cancer. Then you would look and swab what's left there. Okay. All right. You guys already answered part of this question. Colon cancer screening, we go from what age to what age? 50 to when?
Is it 75?
Yes. Very good. So, when do we do it sooner than 50?
Like with a family history of
Mhm.
colon cancer.
Good. So I literally just this past week had a patient that came in, and her dad was in his 30s when he was diagnosed with colon cancer. So she would be starting in, and I don't remember. So if let's say he was 35, then she would start at 25 with her colonoscopy. And then after 75, it's not that we don't ever do colonoscopies. We just do colon cancer screening. Okay. And anytime a patient so even if they're in between, if they're 50 to 75, but they're having weight loss, blood in their stool, and you're like, and and they're 60, they've never had a colonoscopy, it's still at that point not a colon cancer screening, it's a diagnostic colonoscopy. Okay. And it's important to differentiate, one, because of the purpose of your exam, but also with billing and insurance, they consider it very different things. And these days there are lots of options for screening for colon cancer. For diagnostic, if the patient's like hemorrhaging, we're having to transfuse them all the time, or having blood per rectum, we're not gonna go and say, oh, let's do an FOBT, because obviously they're going to be positive, right? And we don't give them all these other options of, okay, let's do a CT colonography first. We go straight to a colonoscopy, and it'd be inpatient at that point. But if it's a screening, they have no risk factors, no alarming symptoms, then you have a lot of these other options. Like the fecal occult blood test, it's every year, but they have to give 3 different samples on 3 different occasions. So it's a little bit cumbersome. I still have one patient that chooses to do it that way, and I can't convince her otherwise. But we also have the Cologuard. So it's a DNA stool test that you guys may have seen the commercials for, or flyers or something, but it's really neat. And I have really been glad to have this as an option, because I've had some people that have refused to do any kind of screening, but now we'll do it. But it's a kit that the company sends to the patient. They send the sample of their stool back to the company runs it and then sends us the results. And if their test is negative, then they're good for 3 years. If it's positive, then they have to do a colonoscopy anyway. But it does save them that trip to the OR and the prep, because for the Cologuard, they don't have to prep, they don't have to do anything special. And in a lot of them, it's that drinking the GoLYTELY, that prep to do the bowel cleanse that they hate. Not really the procedure itself, but the clean out beforehand. Okay. Okay, and then this chart is something that I just refer to, telling you when to follow up. So it depends on how many polyps are found, the size of the polyp that's found, and the type. So they could have to follow up within 1 year, anywhere back up to 10 years if there's nothing wrong. Okay. With breast cancer screening, depending on the source you look at, 50 down to 40. 50 is still the general consensus outside of the Breast Cancer Association. But we have from 40 to 50, it's not wrong to do. It's a conversation to have with the patient. And if they are like if they're a little bit higher risk, but they don't have like really close family history, then it's kind of up to the provider's discretion before 50. 50 and above, every single person should be getting screened no matter what. And we do screen even sooner than that if they have a really strong family history, like their mother was diagnosed with breast cancer at a really young age, then you could screen sooner, but this is the general consensus. Okay. Bone mineral density screening. This is why on that first question, the 52-year-old, we weren't doing the bone mineral density screening because she was 52, not 65. Less than 65, you can screen depending on certain risk factors. Do you guys know any other reasons why somebody might be screened sooner?
If you have a fracture from something that probably shouldn't have caused a fracture in someone that's healthy.
Right, like so a pathologic fracture. Right. What about any kind of medicine that somebody might be on for an extended period of time?
Steroids?
Yes, very good. Yeah. So steroids interfere with our bone density. So somebody, that maybe was diagnosed with lupus in their 40s, it would not be wrong to screen them sooner if they're on these chronic steroids, right? Very good. Okay. And then T-scores, that you would look for, and then different pharmacologic agents that you potentially could give for prevention versus treatment for osteoporosis are on this slide. All right, next question. Your 18-year-old female patient presents with hesitancy, frequency, and dysuria. What do you treat with? Sorry, some of you guys were answering my other questions in the chat, and I did not see them. I apologize. Okay. So a little bit of mixed answers. So for this patient, we would test before we treated her. That would be because she is a young female. This would not be considered, if we suspected a UTI, we would not suspect it to be a complicated UTI if these are truly her only symptoms, right? If she's running fever or having severe pelvic pain, things like that, then then we would treat her a little differently. But if they're just having some of this hesitancy, discomfort, some burning with urination, then you would wait and test before you treat them. Also, because being a young female, and you also would want a little bit more history, right? Is she sexually active? Because then some of these symptoms could be from something different, and you want to try to use, you want to be conservative with your antibiotics, right? And while you're testing her for UTI, you're going to test her for gonorrhea, chlamydia, wet prep, depending on what all you're wanting to do for her, and wait for the culture and go from there. Okay.
I was just wondering, so
Uh-huh.
did you say this is considered a complicated UTI?
Not a complicated, I'm sorry.
Okay.
Yes. Yeah. So with whenever you look in UpToDate or like the Epocrates app on your phone, whenever you're trying to pick antibiotics and things, a lot of the time you'll have to decide if you consider it to be a complicated versus non-complicated UTI. And for her, I would say non-complicated because these are her only symptoms. Okay, so next question. 68-year-old female with worsening urinary incontinence. What's the most common type of urinary incontinence? Okay, interesting. Okay, so let me go to this next slide. There we go. Okay, so here on this slide, and some of these slides are mine, some of these are not. So and this one in particular, I don't know where it came from, but you guys are right according to this slide. The answer to this question is supposed to be mixed, and so you guys are right. Most other lectures, when I do it, they end up picking mixed anyway. So I don't know if you guys were given different material or you guys all read something different ahead of time, but you did great. So stress incontinence is very prevalent, very common, especially after childbirth. It's anecdotally the most common thing that we see. So anytime they're talking about that they like leak a little bit of urine after they cough or sneeze, is pretty common. And then urge, obviously, they'll just out of nowhere all of a sudden have the urge to need to go. And that, let me see. Okay. And then obviously the mixed is whenever they have the combination of the two, right? All caused by very different things. There's a little bit of overlap, but if you go, let me see on this slide, the functional urinary incontinence is not something that you hear very commonly, but it's one that is very different from the stress, urge, and mixed. Stress, urge, and mixed are very commonly overlapping. But functional, you want to think somebody that has like dementia, they're just not even aware of an urge. They don't do anything to cause the stress, but they're not even aware of the urge, and they just all of a sudden urinate on themselves. It's a lot of it is like an overflow incontinence. But then or like they might feel with a functional, they might feel that they need to go, and they might they have that urge, not a last minute urge per se, but they just can't, they physically cannot get up to walk to the bathroom, so then they urinate on themselves. Okay. All right. Condoms will not provide any protection from which of the following STIs? Okay, great. So yes, you guys are right. With all of those, you will get some protection. All right. This one is a question that I don't think is necessary for us to do. And I apologize. I alluded to this earlier, but my slide set is, I don't know if Jessica emails you guys a slide set or not. And so I don't know if mine is probably different from the one you guys have, because I took out several things. And I think I might have some things in here that you guys might not have. So I apologize if it's not the same as what you guys have, but I think for the most part, it is the same. Just, I'm just going to the slides that are more relevant for you guys. Let's see. Okay, so with STIs, STDs, whichever you want to call them, the key thing is if you have any reason at all to screen somebody for an STD, you just do it. And if they're having any type of symptom, they're like, no, this could be, you just do it. In the ER, in fact, they not only test them, they go ahead and treat them for the STD instead of waiting for the result to come back. In clinic, we have the luxury of being able to call them up and let them know of the results. But if they're a patient that I'm like, I don't know that they're going to come back and take this medicine, then or they say, if you call me tomorrow or the next day and tell me that I have to come back to take a medicine, I'm not going to have a way to get here. Then in those circumstances, we would go ahead. So you want to look at your patient population, why they're there, if they're having any symptoms, but then if they're pregnant, and even if they're not having any symptoms at all, we still screen them for all the STDs. Okay, except for herpes, we don't screen for that. There's just not really a great way to do it. So if one of you guys wants to make a lot of money and figure out a good way to do that, that would be fantastic. Okay, so we'll talk through some of the STDs. Gonorrhea, also sometimes called the clap or the drip. You can see oral, GI, rectal, or disseminated. You can be asymptomatic and have it and carrying it around. So something that you want to have a low threshold to test or treat for. How do we test? Let's just start with this. How do we test for gonorrhea? Is it, I know what it says something on the slide, but do we have them, do we do a swab? Do we do a urine? Is it a blood test? Is there a combination, or what do we do for that?
Is it a swab?
That is one of the options. That is correct. Yes. So for a long time during most of my med school / residency, the swab was the only option. But now we also can do a urine sample and detect it that way. And it's very similarly sensitive. I don't know the exact percentages, but very similar. So good. We do not have a blood test that we use in clinic to test that. So swab, an endocervical swab, or a urine test. Okay, we're gonna skip over this. Okay, and then here is, okay, can you guys see my cursor on the screen?
Yeah.
Okay, so I know like sometimes people will talk about pictures and you're like, I have no idea what I'm looking at. So here is the speculum, okay? And then over here is part of the vaginal wall. And then here is the cervix, okay? So it looks like if this discharge wasn't coming out, sometimes people will say like a bagel, where you'll have this little hole in the middle, right? This is a very angry cervix. It's very red. Normally it's like a pinkish color, okay? But this is a very friable, angry cervix. And then you have this nasty discharge coming out of the cervix. And right here, endocervical swab is where we would put that swab to test for gonorrhea. Okay. Okay. And then here it's showing you all these adhesions that you can get with PID. And you would treat somebody with suspected PID differently. And obviously they have a higher risk of not being able to have children in the future because of this damage that they have. Okay. And then these, you'll see, sorry, my cursor keeps, okay. So you have these Bartholin's glands, cysts here. And so if you do an exam, you can see somebody and it may just be there and you might incidentally see one and find it and it's not causing them any problem. And that's fine. But they can get very tender, swollen, even have pus coming from it. And so there's a variety of things that you can do. One is just watch it, but another is doing an IND and antibiotics, just depending on how severe what their symptoms are at the time. Okay. All right. This slide, there we go, has the sensitivities and specificities on there for you, and that you can use a urine specimen. Okay. So treatment of gonorrhea. So we'll go back to here, right? We had treatment of gonorrhea is IM ceftriaxone, right? Is that fully the correct answer?
It is when you know for sure it is gonorrhea. But
Okay.
if you haven't ruled out chlamydia, you need to give azithromycin too.
Okay. Yes. So good. Let's say that I tested them for gonorrhea and chlamydia was negative. Do I still just treat them for gonorrhea?
Don't you still treat for both?
You do. Yes. Because so you, I'm sorry, Taylor Whitney. I'm not sure which one was your first name. I'm sorry. You were right in that if you could theoretically for sure rule out chlamydia, then you would be able to just treat them for gonorrhea and give them the iron ceftriaxone. But because now we'll go to our next slides. Okay. Because chlamydia is intracellular and you often get a false negative test, you always treat them for gonorrhea and chlamydia. If I test somebody for gonorrhea and chlamydia and the chlamydia is positive and the gonorrhea is negative, what am I going to do? I'm sorry, it just got really dark in my, I'm gonna turn the light on really quick. What do you guys see? Anybody know? If you don't, it's okay. It's a little bit confusing. So if you test for gonorrhea and chlamydia, which we always test for gonorrhea and chlamydia at the same time, because that swab that we do endocervically, it's just the one swab for both. So the only time you wouldn't was if you just by mistake didn't click both boxes when you were putting in your orders on the computer. If you accidentally only clicked one versus another, then you would always be testing for both. But if I tested for gonorrhea and chlamydia and the chlamydia was positive, the gonorrhea was negative, then you only need to treat for the chlamydia, because it's the chlamydia that is the one that's difficult to get a true negative. But if it's positive and you're good. And if gonorrhea is negative, you're good. Does that make sense to you guys? Or is anybody still confused? Okay, perfect. Okay, so that's basically what I just talked about. It's obligate intracellular gram-negative bacteria. You can do the zithromycin 1 gram PO once, or you can do the doxy BID for 7 days. But because people aren't great at taking antibiotics, we often just do the 1 gram PO once of the azithromycin for chlamydia and be done with it. Okay. And that's the one that I'm talking about, that they'll give that to them in the ER before they leave. Okay. So you can also be asymptomatic with chlamydia, right? So again, that's why it's important to use protection, and also it's very important to, not everybody is always great at doing this, but whenever we call the patient to tell them that they were positive for something and send the antibiotic for them, you have to tell them to abstain for 7 days and to also get their partner treated. In Oklahoma, unfortunately, we're not allowed to just send a partner script with them. In some states, you can do that, but in Oklahoma, we cannot, because we have to be an established. They have to be an established patient with us. We have to have a relationship with that patient. We can't just send and give any random people prescriptions, right? But anyway, whether that's right or wrong is here nor there. But so in Oklahoma, you have to warn them and say, hey, if make sure that your partner gets treated and they're made aware, and they're more than welcome to come into clinic, and we can treat them for you, or if they go somewhere else or whatever. But the health department, if the partner doesn't tell them, the health department will make sure to make them aware as well. Okay. All right. So all the different places that chlamydia can be positive for. So, and I know this is like our women's health section, but I do OB and women's health and a lot of ped stuff too. So because of the places that you find chlamydia, that's one thing that you want to be mindful of. When a baby comes to see you in clinic, if you are like, if you're a family medicine provider like me, sometimes I was the OB for the mom and I know mom's entire history, but sometimes I wasn't the mom's OB. So I'm seeing this baby, this family for the first time. And if this baby is coming in with the gunky eyes, you have to make sure that you ask the mom if there was any history of STDs during the pregnancy. And then unfortunately, even if she was tested and was negative, she could have contracted it later on in pregnancy before delivery. And baby's born in through the vaginal canal and gets this chlamydia in their eyes and into their lungs. So that's a staccato cough that you'll hear about at some time on the peds wards or your peds rotation. But this really gunky, gooey eyes is something that you might potentially see. More commonly, it's not chlamydia in their eyes. It's more commonly a clogged tear duct. So always have that in the back of your mind too. But just you want to think about, tie everything in together and always keep all the parts connected and be thinking about everything. Okay. And then here's chlamydia in, so mom very irritated, and then the male with that drainage. Okay. And then here's the picture under the microscope. Not really much else for me to tell you guys with that. So I talked to you guys about gonorrhea with the testing. So gonorrhea, chlamydia are very much paired together when we test them, right? And so like even when we do our notes, we usually do GC/CT negative. You test for them at the same time. You can do an endocervical swab or urine for gonorrhea and chlamydia. Okay. All right. And we already talked about that. All right. So trick. Trichomonas is the mobile flagellated protozoa. Okay. And you treat it with metronidazole. You might see in your questions, keywording wise, that like a green frothy discharge. I don't know that I've ever been able to really differentiate green from other colors of discharge ever. So I wouldn't count on that unless it actually says that in your question stem. How do we test for trick?
What now?
Yeah. So you'll get a swab, right? A urine is not a standard of care way to test for trick, but you can see trick in the urine, or even on a pap smear, actually. If it's pretty bad, their results will come back with that. But standard care, yes, you do the wet prep, and it's a vaginal wall swab. This one, when you test for trick, you're not going into the cervix. Okay. And there's some pictures for you. Some more pictures of it, very angry. So this one, you'll see the strawberry cervix description. Okay. You can see the little strawberry cervix appearance. Again, with like gonorrhea, you can see a very angry cervix as well. So you don't want to always just count on that visually, but if your question stem says strawberry cervix, then you're going to pick trichomonas. Okay. All right. So trichomonas, most commonly we use metronidazole. You want to tell them to make sure that they do not drink alcohol with it. You can make them feel very, very sick. That's really it on the slide. Okay. Mycoplasma. It's not an STD per se, but it is something that can be passed with intercourse. And it's something that can, again, like in pregnancy, any type of infection basically can cause problems with the baby, with preterm labor. So if mom is positive for mycoplasma, we usually will test the dad and go ahead and treat him as well, or else they just kind of keep passing it back and forth to each other, very similarly like an STD. So we just kind of try to eradicate it that way. And then you can do the azithromycin 1 gram again for this. Okay, HIV, again, something that you want to have a low threshold for testing. Again, with pregnancy, we test every single woman, even if they were tested with their last pregnancy, or if that was a year ago and they haven't had any new sexual partners. But anybody that asks for the HIV testing, we do it. If they have, again, any reason that you would need to test them, if they're a high risk person with multiple sexual partners, or they weren't using protection, any symptoms whatsoever that you're concerned about HIV, so night sweats, then, or IV drug user, anything like that, then you'd want to just go ahead and test them. Okay. And don't forget either that you guys, with as students, that you get needle stick, you can get tested with your needle stick coverage, and they'll cover your initial testing and all of your follow-up testing, like 6 weeks, 3 weeks, or 6 weeks, 3 months, and 6 months following exposure, as long as you want to. Okay, but there is potential follow-up testing that you would need with just a one-time test at the beginning. You can't 100% say that that person is completely negative if they've been exposed. Okay. All right, so you guys answer this question for me. Okay, good. Okay, so lots of advantages and disadvantages with the condoms. It's not, if somebody can reliably, consistently use a condom every time, then it has pretty good efficacy. But the problem is that people don't do that. So we pretty much never just offer that as the birth control to anybody. If they want to use it, that's fine. But if somebody's goal is to not get pregnant, we usually don't really offer this. Male and female condoms right? And we'll talk through the different birth control options here in just a second. You guys answer this question for me. Sorry, I think I'm covering up part of the screen. I apologize. Okay, good deal. So does anybody know why the answer is not B?
It causes heavier periods.
It can, yes. A lot of like the textbook answers is that the copper IUDs are not actually supposed to affect the periods at all, because it's not hormonal, but there is some evidence that the copper itself can cause some like chronic inflammation and irritation, which is how the copper works as a birth control, and that irritation might cause some chronic bleeding, but in theory is not supposed to affect the person's menstrual cycles at all. So if it's somebody that does not want to have periods and they're like, oh, well, yeah, I don't want to have any periods anymore, so I'm gonna get the IUD and I'm gonna get the copper IUD because I don't like hormones. Like, well, sorry, it doesn't work that way. The copper IUD is not going to get rid of your periods. And just like Whitney, I'm sorry, said that the periods can get heavier. Okay, very good. Come on. Okay, so at this point, I'm going to kind of steer away from the slides. Let me go back to, okay, let's escape from here and go to trying to see you guys again. Sorry. I have no idea how to see your faces again. I don't know what I'm doing. Okay. I'm just going to talk, but I want to see your guys. It's okay. Okay. So what I like to do whenever a patient's coming in to talk about birth control, a lot of the times they come in not really having a great idea of what they want to do. Sometimes they do, sometimes they don't. But I kind of walk through the steps with them and let them know all the different options. Okay, so we talked about condoms, and then there's the OCPs, right? There's combined oral contraceptives, and there's progesterone only contraceptives. Throughout, anytime you're thinking about contraception, period, you need to think about, okay, is this estrogen, is this combined, or is this progesterone only? Because depending on the patient, you may need to be avoiding estrogen. Okay. Does anybody know why, like what certain circumstances we would need to avoid estrogen?
I mean, patients that have had like previous blood clotting issues is like a pretty big contraindication for the estrogen birth control methods.
Yes. Very good. And then anything else?
Over 35 and smoking.
Yes. Very good. Very good. So, so yeah, family over 35, smoking, any family history, stroke, heart attack, things like that. Also, if they've had migraines with aura, that's another contraindication because it can make their migraines worse. Okay. So we start with talking about, so there's condoms, pills. Again, I usually kind of make the joke of, you'll have to remember to take these every single day at about the same time every day. And I'm not very good at even remembering to take my vitamins every day. So I probably wouldn't recommend that. And they laugh, and then we just can continue. Okay. And then we talk about the Xulane patch. It is a combined contraceptive. Does anybody, I'll just tell you guys. So it's a patch form contraceptive that looks like a little square Band-Aid. It's not very big. It's, if you guys are looking at the screen, I don't know if about that big. And you just alternate where you're wearing it. You can wear it on your shoulder, your hips, under your bikini line, in the front and the back. Its options are pretty limitless. There's just a couple of places you can't wear them, and it says it on the box, like not on your face or your chest or something like that, and which places you wouldn't really want to wear them anyway. The biggest complaint that I get with those is some skin irritation. So if there's somebody that is very sensitive to any kinds of adhesives, Band-Aids, skin tape, anything like that, then it might not be the best option. But it is better as far as not having to remember a pill every day. It's the patch that they wear. They wear it continuously and then change every 7 days. And just like with the pills, with the patch, you can skip the placebo week. So the pills will be the 3 rows of the hormone containing pills, and then the 1 week, it's usually white, of placebo pills where they have their period. With the Xulane patch, they can wear one and change it for 3 weeks. And then on the 4th week, not wear one and have a period, and then resume the following week. Or they can just continuously wear a patch every single week. Okay. Then there's the NuvaRing. It's also a combined. It is a rubber band type device. It's a thicker rubber band that a patient will insert like a tampon. So it starts off as a circle about like that, and they pinch it in the middle. So it makes like a figure 8 shape. They pinch it in the middle and then insert it like they're putting in a tampon. So if it's a patient that has never worn a tampon before, that's usually a question I ask them. Then they might have a little bit of trouble, but if it's still something they want to try, then by all means they still can. But it's also a neat option because they can wear it for 3 weeks, and then on that 4th week, remove it and have a period, or again, change it every 3 weeks and wear it continuously. Okay. And that one's also a combined. Let's see. Okay. And then we have the Depo-Provera. It's an injection that and this one is a progesterone only. So we're switching to progesterone only. Okay. So Depo-Provera is an injection that they get every 3 months. It's also a pretty good option because, again, you don't have to come in, or you don't have to remember to take a pill every single day, or even every month. But they do have to physically come into the office every 3 months. It's not as cumbersome as having to wait to see the doctor each time, because they just come in and as a nurse only appointment. the first time they see the doctor for the doctor to say, okay, yes, you can start the Depo-Provera. But then once they're established on it, then you just come in for nurse only appointments, as long as you stay within your window of time that your next injection is due. And there's a pretty good window of time. It's not like they have that one day that they have to come in or they're done and they, then they're past due for their shot and they can't have it. It's like 10 days. I can't remember exactly how many, but it's something like 10 days. So it's a pretty fair open window where anytime during those 10 days they can come in and get their next shot. Okay. Then we have the Nexplanon. You may see Implanon in some places because that's the old version that would not show up on x-rays. And then the Nexplanon is the newer version that does show up on x-rays. And it's a little device about this big, like the size of a match, that we insert right about here in the triceps groove. We insert it and then they're covered for 3 years. With that device, the biggest complaints that we get is breakthrough bleeding. So we actually have a consent form that the patient signed for it, a special consent form for the Nexplanon versus any other devices, because of the breakthrough bleeding, really. Basically warning them that their periods might be longer, might be heavier, or they might not have any periods at all. And that every person is different and we cannot predict who is going to respond in what way. But very frequently, and this is similar to the IUD initially, but as your body is adjusting to this implant, I have women, like, they'll have a period for like 20 days and then they might have some spotting the next month and maybe a little bit the next month, and then they don't have a period for the rest of the 3 years. But I have some women that continuously have long periods. It's almost none of them have heavy blurry periods all that entire time. It's just more of an annoyance where they have like spotting for extended periods of time, and can be annoying for a woman for sure. So it's something that we want to warn them about. I more commonly see the Nexplanon used in my like young teenage age where they may really not be ready for an IUD, but they and their parents know that they need some type of protection because they don't want them getting pregnant as a teenager. So they're giving them that sort of protection, and they don't want them to have to remember a pill every day. But they want some type of a long-term protection. So that's where I more commonly see that. I have grown women that use it too and love it. But it's something that we just can't predict the reactions that people might get. So leads us up to the IUDs. There's several IUDs available now. Most of them are progesterone only. And we talked about that, the one copper IUD. We actually don't even place those in my clinic anymore. I have placed them, but we don't even order them anymore because we almost never have anybody request that one anymore. But so there's, for the other progesterone only IUDs, we have Mirena, which is a 5-year IUD, as far as bleeding goes, but it's actually FDA approved for 7 years for birth control now. But if it's for somebody, progesterone only IUDs is one of the great treatments that we have for women that have heavy bleeding. Like fibroids in particular, they may have like polyps or they may have just been somebody that's bled heavy their entire lives. then the IUDs are a really good option. And we do have some patients that have the breakthrough bleeding. And again, their bodies have to get used to having that birth control in their body. But because the IUD is localized into the uterus versus the Nexplanon having to travel systemically, we get a lot better control of the periods that way, because it's right at the target site. So more common than not, I have very good results with the IUDs. But if the bleeding is the main reason that you're putting in the IUD, you don't want them to have it for more than 5 years, because a lot of them will start kind of bleeding again after that. But for birth control, 7 years, it's FDA approved. And then we have the Skyla and the Liletta and the Kyleena. Those are all other options with progesterone only IUDs. The Skyla, Liletta are 3-year, and the Kyleena is also a 5-year. The difference with those other ones is that they're a little bit smaller in their circumference. So I don't have a way to show you guys the real device right now. But we'll say like this pencil is my device that I'm using to insert an IUD. So I'll have a tube type device like this, and it's a lot smaller in circumference than this pencil that I'm holding. But the device will actually be inside, the IUD will be inside of my insertion device. And then the Skyla, Liletta, and Kyleena, their circumference of the insertion device is slightly smaller than the Mirena. And the advantage to that is that for like a teenager, for example, or any woman that has not had a vaginal delivery, their cervix is closed, right? And so it's a little bit more difficult to get this device through that little bagel hole whenever they have not had a child. And frequently we have to use what we call a dilator. So it's another device that is a lot smaller than this, that gradually gets bigger, that we insert and spin and insert and spin to gradually dilate the inside, the endocervix, so that then I can then pass my insertion device through the cervix. And so if somebody that's already had children or multiple children, then between the two, it really doesn't matter. And I have placed Mirenas in young teenage girls that have not had children either. So that's just the concept behind the other ones. But in real life, that's kind of the different things that we run into and do. I think that's it. Do you guys have any questions about any of the material or anything that we've talked about? Let me. Pre-existing hypertension. Sorry, Christopher, I am seeing your question. I have never excluded somebody from birth control because of hypertension. It may be a relative contraindication, but I've never seen it as an absolute contraindication before. So I don't know if that helps you. I'd have to see the exact question to be able to answer it better for you. But as far as I know, and I could definitely be wrong, and I would love for you guys to teach me anything that I don't know. I have never used that as an absolute contraindication for any of my birth control. Weight though, if somebody is over certain BMIs, that does exclude them from certain birth controls, like the Nexplanon, for example. Okay, relative contraindication. Okay, yeah. So with the IUDs, sorry, it says Tyler Whitney. I kept saying Taylor. I apologize. Whenever I cut the strings of an IUD, I personally at first leave them a little bit long because I cannot tell you how many times I've had women, one, not be able to feel their strings because their strings were too short, or two, not even be told they were supposed to check their strings. So after you get an IUD, you're supposed to check your strings every single month to make sure that you can feel them. But if the string does bother them or does bother their partner, then yes, I do trim them if they want me to. A lot of the times the strings themselves actually end up curling up on their own, kind of up and around the cervix themselves over time. So a lot of the time, no, they really don't have, I really don't have women coming in complaining about their strings very much at all. Like maybe I've had one person initially after placement that wanted their strings trimmed, but I've pretty much never had anybody else come in saying anything about it. Cool. Anything else, you guys? All righty. And then did you guys have any questions about the Bob case or the quiz? You guys did all of that already, I believe. Okay, good deal. Well, I really enjoyed having you guys, and I appreciate you being flexible and switching to a Zoom call for me. And now I have this recording available for future reference for other rotations that potentially might need it. So I appreciate you guys being willing and flexible for me. And if you have any questions and down the road, just let me know. And I will potentially be working with you guys later down the road as well. So have a great rest of your day and good luck with studying, and let me know if you guys need anything, okay? All right, thank you guys.